how hormonal signals are organised inside cells and how there's a molecular architecture within the cell that controls what happens very precisely, and how we can manipulate that at some levels to a therapeutic advantage. We see various different things. We're really primarily focusing on chronic diseases, usually diabetic comorbidities, and we've identified a family of about 50 proteins that are all involved in this sort of local organisation within the cell. And what we're doing is trying to map out some of the other molecules that they communicate with, so that we can then develop small molecules that can interfere with those basically binding events. It's like Lego. Well, I think that the advantage of trying to do this, which is sort of counter to the way most of the big pharma actually is working at the moment, is that their interest of big pharma is really to make small molecules that are cell soluble, that target pockets and grooves within proteins. But to really be able to gain specificity and hopefully lower the effective dose of a drug, you actually probably have to target protein-protein interfaces. And that's something that has generally been out of the realm of what's been possible with conventional drug discovery. And it's only really through research that we're beginning to understand some of the principles that are going to have to be involved for the next generation of drugs. And it's actually looking at those binding events rather than enzymatic activity. Diabetes is a multifaceted disease, as is cancer or heart disease, and that's why it's endemic, because it's so complicated. It certainly has its origins in the defective glucose homeostasis, but it ends up with defective circulation, diabetic cardiomyopathy, vision problems, and amputation. Those are all aspects of diabetes that have to be treated independently. Some of them can, some of them can't. One of the biggest problems is hypertension. 85% of diabetics become hypertensive. Once you become hypertensive, you're going down a slow path that's going to result in some of these other problems. So I think there will always be more and more drugs. I mean, the projections, I think, for 2050 is that there will be 60 million diabetics in the United States. There are already 23 million diabetics. It's a staggering number. So I don't think one cure, we do have a cure at one level, which was in 1913. It was the introduction of insulin by Banting and Best. But it's not quite that simple. They know how to manage it. You can't cure it. I mean, type 1 diabetes is genetic. Type 2 is sort of slow wasting away. Drugs that can manage it would be what you would want. It's a bit different than, say, well, in some respects it's like cancer, in other respects it's not. I think that generally people that work in research don't take into account the effect of what will happen. They can use most of the research, unfortunately, is done in mice. Mice don't get diabetes. Mice don't get thyroid cancer. Or if they do, we don't really want to have to cure it, but we do want to be able to cure humans. And so there's a bit of a disconnect. And I think that that's also where, to be fair to the pharmaceutical companies, they recognize that, much more so than people in my position. And I think that really, as we develop in the next generations of researchers, they're going to have to be more cognizant. I mean, bench to bedside is a term that's used a lot. I don't think people really know what that means. It's, you've got to understand both sides. I'm in the process of establishing an institute which is 50% clinicians, 50% basic scientists, and I think that both groups can learn a lot from each other, and they need to work together as a team.